All right, so this is our first patient. We have a 65-year-old, and I want you to regard the astigmatism, and here's the axis to look at. The steep axis is superior, and since Kerry will be sitting temporal, we're going to address that, and so we're going to address that with the IQ toric. And he had, his decision was between a T4, T5, and so he's going to be doing the T4, and he's going to be doing it with the, doing an arc superior. So here's what we're looking at, the 1.53 at 84 degrees is where the LenSx analysis has him. Good accurate K readings with the LenSx. So after the LenSx analysis, then you go to the toric calculator, and the toric calculator, you can see here that he has put his surgically induced astigmatism at 0.25, and that he'll be looking at the T4 right here, and 85 degrees is where he's aiming. Kerry, you're on our screen.
All right, good morning. Thanks, good morning, Don, thanks again. So let's get started. I've already put a numbing drop in her eye, and we've put a speculum in her eye. I like to use a locking speculum. This is an old speculum from Goiter, a Neuhann speculum. Cheryl, I want you to look right at that red light. That's excellent. That red light is not a laser. It's just something for you to stare at. We're in focus. Docking is really one of the key portions of any of these procedures, so you want to make sure you've got good exposure. That looks terrific. Look right at that red light. Cheryl, you're doing great. And I like that very much. The eye is nice and level and everything looks good. Just look straight ahead for me there. Wonderful. Great job, Cheryl. Perfect. You're doing wonderful. Hold nice and still. Suction, please. Excellent. Wonderful. That looks terrific. So now we're just going to go ahead and line everything up, and you can see an outline of my incisions. That's a trapezoid incision. That looks good. A little further out would be great. Good. And that's my side port incision she's manipulating now. We're going to just move that out not quite so far. Right there looks perfect. Now let's go ahead and center our lens. This is centering the capsulotomy, and that looks good. And we're ready to go to an OCT scan. So we've got a really nice flat dock. This is basically an unwrapped image, and you can see the nice thing about the new software is it pretty much auto finds the anterior and posterior, I'm good with that, surfaces of the lens capsule. Now we're going to image the lens. We've got a nice centered dock. Let's move this anterior, perfect. And posterior I'm actually good with. So we can leave that exactly as is. Corneal thickness is next. We're going to take an OCT. This is a 3-plane incision. I'm good with that. See how quick everything moves from screen to screen, because the software pretty much automatically finds all of your previously saved landmarks. That's good. Cheryl, we're getting ready to get started. And here we go. Treatment's about 55 seconds. Wonderful. You're doing great. Everything looks terrific. Now you can see the bubble pattern underneath the lens capsule, and as the bubbles start to break through the capsule, as are occurring now, you'll see the bubbles come up into the anterior chamber. That's exactly what we want to see happen. Cheryl, you're doing perfect, dear. Just keep looking straight ahead. Great job. We've got about 35 seconds. We're just about through the capsulotomy portion of the procedure, and now we're going to move to the lens division. This is a cruciate or a cross-shaped lens chop, and I've also added a 2.5 millimeter cylinder to it. This was first described by Steve Slade and Bob Cioni. It's been very effective for me. We can see gas build up in the lens, and notice as this comes anterior, we should start to see some bubbles right there come into the anterior chamber as we decompress the lens. There's the arcuate incision, the primary incision, perfect, and the secondary incision, and we're done. Cheryl, you did perfect. All right, so that really was it for the LenSx portion of the procedure. And I'll talk about some of the specifics of why I set things the way we did in the operating room. But she did great. We're just going to move her to the operating room now, Don.
So Bob, and I'm going to have Bob and Kerry kind of talk about what the parameters are that Kerry has set for this patient. Bob, maybe you can address those.
Yeah, to begin with, it looks like Kerry has a 5mm capsulorhexis. Since we want to cover the optic with about half a millimeter to a millimeter of residual anterior capsular rim, you really need that to be about a 5mm capsulotomy if you have a 6mm single-piece lens. That way you have nice, even coverage. You also saw that he had the lens chop just inside of that, so that was a 4.9mm lens chop. By making the lens chop a little bit smaller than the capsulotomy, you can bring that lens chop all the way up near that anterior capsule without risk of damaging it. And we're finding that somewhere in the 4.5 to 5mm lens chop is really all you need to get a real nice, effective chop. Are we going to see a screenshot of the OCT so I can describe
I
that?
think that we're going to try to get a still of the OCT so that the surgeon's screen so we can address that. I was impressed by the, there's his surgical plan.
Okay,
maybe you could address that.
Yeah, let me speak to this. You can see in the video image that there are some pre-marks of the horizontal axis, so you can, with this 213 software, adjust your settings on your screen to match the eye so that you're certain that you're oriented properly. The upper OCT image is an OCT scan showing the elevation of the capsule, the lens, and cornea relative to the plane of the lens of the laser. It's almost as like a world map that's rolled out flat. So it shows the 5mm capsulotomy area that's going to be treated, unrolls it so you can set the anterior and posterior gates of your treatment to make certain that you're going to treat the area of capsule that you want and that you hit that capsule all the way around the 5mm circumference. Then in the lower picture, you see the area of the capsule that's treated as that purple line, those thin purple lines on the anterior portion of the lens, and the yellow shaded area is the area that's going to be treated by the lens chop. And it starts off giving you a suggested offset away from the posterior and the anterior capsule, but you have the option to move that if you want. I like to take the posterior portion of that lens chop, that shaded yellow area, just down to the interface between the nucleus and the epinucleus, and that's right where the arrow is pointing. If you do that, it tends to free up that epinucleus a little bit better when you're removing the lens. The docking was nice and flat. You can see that on the upper image, and that's what you hope for. If you get a markedly tilted dock, you may find that your capsulotomy is off-centered or your arcuate incisions are off-centered. So you do want to have a nice flat dock, and Kerry's become very good at this. Those who have laser experience, it'll probably come a little bit easier. For those who don't, there's a little bit of a learning curve. But the flatter the dock, the better the treatment you're going to get, and everything's going to be better centered. Everything went beautifully. You saw bubbles develop underneath the anterior capsule. As he started the capsulotomy portion of this, they were larger bubbles, which is what you expect to see, and then as that laser works from posterior to anterior, those bubbles begin to percolate through the capsulotomy and become very fine bubbles, and you want to see that those bubbles percolate all the way around the 360 degrees capsulorhexis. When you see that, you're pretty darn certain that you have a nice free capsulotomy.
Steve Slade, you've seen the efficiency of the laser changed. I'm impressed by this 55-second treatment. What have you seen evolve?
You know, it really has evolved in the last couple of years that it's been in the U.S., and it's really only 3-year-old technology. And you know, Kerry's beautiful case really demonstrates a lot of things. Simply a lot of things that you notice, it recognizes the image recognition aspects of it, so it picks up where you want to go, where you tell it to do. So there's no more setting it, there's no more having to decide. It's all decided and planned before you even dock. It's a very clean interface, just the screenshot you showed.
All right, looks like our patient is ready now, so we're going to go to Kerry now at the microscope and proceed with the cataract surgery itself. Kerry, you're on our screen.
Okay. Thanks, Don. So we can see in Steve and Bob, great commentary, and thanks so much for filling in some of the gaps. So I've got some pre-placed marks right here, and her axis of astigmatism was right at about 85 degrees, so I'm going to place my mark right there, right at 85. First thing we're going to do, let's take a peek at what we have. I've got my side port incision over here. This is a trapezoidal incision. It's 2-2 internally, 2-5 externally. And I think what that allows for is a little less ore locking through some of the smaller incisions. And you can see the arcuate that I created over here. First thing we're going to do, and this is a little bit different than a regular, what we do normally with surgeries, we're going to open up the paracentesis. This is a blunt spatulated instrument. I believe this is Steve Slade's design, and we're just going to open up this previously created paracentesis. Now it's important at this point, before opening up the primary incision, to go ahead and place some viscoelastic in the eye, and you really want that viscoelastic to get above the lens capsule as such. Just in case we don't have a complete capsular opening, we really want to make sure that we're stabilizing this anterior chamber so that we can avoid any potential tears that could occur out to the periphery. So we've just opened up the primary incision. It opened up quite readily and quite nicely. I'm now going to place some viscoelastic again, fill the chamber, and just stabilize things. Now we want to look and see how we're doing with our capsulotomy. It's pretty apparent that we've got a complete capsulotomy over here, and over here. There could be a tiny little tag of an attachment here and here. We'll go in and look at that, and I like to do that with a cystotome. I'll just give you a little bit more magnification. How's your view on the screen, Don?
It's very good. We can see this clearly. Thank you.
All right. So I'm just moving the capsule. I'm free over in this area. I'm free in this area. I may have an attachment down here, which is okay. You can finish this with a cystotome or forceps. It really doesn't matter. What does matter is the direction of the forces. You really just don't want to pull centrally, no different than what you do with a regular primary manual capsulotomy or capsulorhexis, because you want to direct the forces circumferentially. Let's have a capsulorhexis forceps. So one of the things you can do is just complete your capsulorhexis. You'll see there was one tiny little attachment there and there, and we are freed up. So that could easily be done with either a cystotome or forceps. So if we just take a peek at what we have, here's our 5mm capsulotomy. I have a lens chop that's just inside of that, 4.9. And if you noticed, I brought the lens chop anterior inside the rhexis on the LenSx system to sort of help decompress the eye, but clearly there's some air and gas still present. So next we're going to do some hydrodissecting. And I want to just fairly conservatively do some hydrodissecting, and I'm going to try to bring some of that gas forward if it comes. If not, no worries. So I'm just simply going to be injecting and decompressing and freeing up the lens, making sure that it rotates nicely, which it does, with some nice hydrodissection. Last, we're going to do a little bit of hydrodelineation, and oftentimes you'll see the gas moving with some of that hydrodelineation. And there's that gas bubble just kind of moving. All right. So now we're going to use ultrasound, in this case Ozil. This is a mini tip. This is a 45-degree angled mini tip, slightly more efficient at removing lens material compared to a mini flared tip. But this is Ozil. And the technique to remove this lens in conjunction with LenSx is a little bit different. Instead of a typical divide and conquer, or stop and chop or chop, we're just going to actually core out this central 2.5mm nucleus. You can tell I've already got pretty good lens separation. I've got 4 little pieces of this pie within this 2.5 millimeter area, and I'm just going to core that out.
We can see he's on ozzle right here. When you see amplitude, that means ozzle. And when the line is diagonal, that means he's linear.
Okay, so I've cored out most of that little central area. And that'll do a couple of things for me. First, I'm going to separate and make sure I've got, remember my lens chop went to 4.9, but if I just separate, I'm going to propagate that lens chop all the way across, and you're going to see gas bubbles. See the gas bubbles coming up? I'm just going to be releasing the gas as I do that. I didn't create this lens chop. This is sort of a pre-chop routine that was already done by the LenSx.
Yeah, that's good.
And once again, I'm just going to separate the lens chop that's already been placed, and that looks great. And we're going to do the same thing over here. Excellent. Cheryl, you're doing very well. And we're going to do the same thing over here. Excellent. Okay. Next, we're just going to go to quadrant.
Well, Kerry, it looked like you were able to separate without having to really groove or chop. That was just a two-handed separation, right?
Exactly right.
And we can look at the settings here. We can look at his vacuum as he's in his quadrant phase. And we can see that he's on linear aspiration. Now what we can also watch for is that in this area is where ozzle IP will show up. If he reaches his near vacuum threshold, then he gets a little bit of a longitudinal pulse there that will
That's
add
right,
to
Don.
the
So one of the benefits of coring out this central area is it provides a little bit extra room so that I can pretty readily remove these lens quadrants. This is the Intrepid Plus tubing, and with ozzle, watch as I just generate some vacuum, and then as we just remove the lens, look at how quickly and efficiently the lens material is removed right at that tip. I think that's the beauty of ozzle. And with the Intrepid Plus tubing, you'll see how stable that chamber is. So I've pretty much got half the cataract out. We're just going to go around and remove the remaining quadrants. And it's very safe. Chamber's nice and stable. And so that's all of the cataract gone. I've got a little bit of epinucleus that we're going to remove right now.
So this mini
Now,
tip
stay on chop for me.
means
Stay on
that
quad.
the mini tip means that the port and the shaft are the same diameter, as opposed to mini flared, which has a little larger port compared to shaft. So some
That's
people
right.
feel the efficiency of the mini tip is a little better, and they just prefer it.
Right. So we're done now. One thing that's a little different with these cases is we don't tend to have any cortical fibers extending centrally from the capsulotomy. Let's go to INA. Which is a small difference in cortical removal of these patients. In fact, sometimes it's so smooth without any tags, you can believe perhaps that you don't have cortex present, which in fact we know you do. I like to remove the subincisional cortex first.
Now this is a polymer IA. You can see the coaxial with a polymer port. Very friendly to the PC. You can be a little more aggressive in your polishing with this IA. So we've gone from metal to silicone, and now we also have the polymer. So we'll be able to discuss soft tips later as far as IA cortex removal.
That's correct. All right, so cortex is out. She does have still a little bit of a PSC here, polish. And that is a benefit to this polymer tip, is you can get a little bit more aggressive at polishing. And regular cortex, please. Okay. Wonderful. All right. Can I have some viscoelastic? So this is now ProVisc that we're going to be placing in the eye. No, just regular ProVisc, please. So I prefer to use Viscoat to during the phacoemulsification, but ProVisc, a cohesive viscoelastic, is what I prefer to use for lens implantation. So this is a T4 lens, 25 diopter. This is the Monarch 3 cartridge. Look straight ahead for me, Cheryl. You're going to feel a little pressure here. That's perfect.
Well, there we have the D cartridge going through the 2.2 internal very comfortably.
Yep. And we're just going to place this in her bag and rotate the lens around. Excellent. Okay. INA. So her axis of astigmatism was 85 degrees. We're just going to remove the viscoelastic agent.
So that's our goal right there. And so right now he's got the IOL just short of his goal while he's removing some viscoelastic, and then you can move it to your actual axis once you've had some of the viscoelastic removed.
And that's exactly right. So that looks like we're pretty much on axis. Good.
So what we're looking at is right here.
Next, we're going to stromally hydrate the incision. These incisions, in my experience, seal every bit as good or better than my steel incisions, with much less stromal hydration necessary. Now, Cheryl, look right at these two lights for me. That's excellent. So what we have, you can see, she's got a T4 lens. I'm just going to make a small adjustment and help seat the lens under the capsule here, but we've got a perfectly round capsular opening. There we go. We're right here at 85 degrees. And depending on what measurement we use, her lens star, for example, showed that it indicated a T4. The IOL master and topography indicated a T5. And most of us wonder, what are we going to do? What's the best course of action? In this case, I've cut an arc here. I'm not going to open it, and I can use this if needed. If the lens star and manual Ks were correct, we're not going to need to open this arc. If the IOL master or topography was correct, then we certainly could open this arc in the office at a subsequent time.
Harry, we're getting
All
a
right,
beautiful
dear. I
view
think we're done.
of the toric IOL marks. It's very nice. We can see that clearly on the screen.
And just a little bit of antibiotic ointment, and we're done.
That was beautiful.
Actually,
Thank
let me
you
just
very
show
much,
one
Harry.
thing before we are done, is let's just make sure we're self-sealing. Our wounds are self-sealing, and we are done.